educational resources. 1 years, we have partnered. From the time they are born, children with cleft lip and/or palate face many challenges. They struggle to eat, breathe, speak, and even survive. Treating cleft lip and palate requires a range of long-term, comprehensive cleft care interventions. But around the world, there is a severe shortage of medical professionals with the skills or resources necessary to provide this specialized care. This is why SmileTrain, as part of our sustainable partnership model, offers a variety of innovative training and educational resources to cleft care providers around the world. For over 21 years, we have partnered with cleft care professionals at more than 1,100 hospitals in over 90 countries, offering more than 40,000 training opportunities, a number that is growing every day. This includes workshops and resources on nutrition, safety and quality of surgery, anesthesia, speech therapy, perioperative nursing, and more. Many of these workshops are offered in a train-the-trainer format, giving participants the skills and tools they need to go on and train other staff members in their local hospitals, multiplying the number of trainees from any one session. Through partnerships with academic institutions and through our global network of medical professionals, SmileTrain also supports long-term educational opportunities like surgical fellowships and exchange programs. Of course, the barriers that limit access to cleft care around the world also limit access to education and training for the medical professionals who provide cleft care. So SmileTrain pioneers cost-effective, accessible training solutions to reach providers in even the most remote and limited resource settings. In 2020, SmileTrain took on operations of Simulaire Medical, incorporating the world-renowned hyper-realistic training simulations into our portfolio of training programs around the world, making cleft surgery training both safer and less costly. In 2021, SmileTrain and BioDigital launched a mobile app version of the award-winning SmileTrain Virtual Surgery Simulator. This mobile app, which features unprecedented offline accessibility, provides multilingual, interactive 3D training on surgical procedures to supplement hands-on training for surgeons at every stage of their career and skills development. The same year, SmileTrain also launched the SmileFinder app, a patient awareness and mobilization app. The SmileFinder helps patients find SmileTrain-supported cleft centers and provides vital information about treatment options. This tool provides essential awareness and mobilization training for caregivers, social workers, healthcare providers, and other nonprofit organizations. Over the coming years, SmileTrain will scale these programs and resources to bring training and education to cleft care providers around the globe, because we know that behind every smile, there's a team of healthcare professionals who made it happen. Thank you. From the time they are born, children with cleft lip and/or palate face many challenges. They struggle to eat, breathe, speak, and even survive. Treating cleft lip and palate requires a range of long-term, comprehensive cleft care interventions. But around the world, there is a severe shortage of medical professionals with the skills or resources necessary to provide this specialized care. This is why SmileTrain, as part of our sustainable partnership model, offers a variety of innovative training and educational resources to cleft care providers around the world. For over 21 years, we have partnered with cleft care professionals at more than 1,100 hospitals in over 90 countries, offering more than 40,000 training opportunities, a number that is growing every day. This includes workshops and resources on nutrition, safety and quality of surgery, anesthesia, speech therapy, perioperative nursing, and more. Many of these workshops are offered in a train-the-trainer format, giving participants the skills and tools they need to go on and train other staff members in their local hospitals, multiplying the number of trainees from any one session. Through partnerships with academic institutions and through our global network of medical professionals, SmileTrain also supports long-term educational opportunities like surgical fellowships and exchange programs. Of course, the barriers that limit access to cleft care around the world also limit access to education and training for the medical professionals who provide cleft care. So Smile Train pioneers cost-effective, accessible training solutions to reach providers in even the most remote and limited resource settings. In 2020, Smile Train took on operations of Simulaire Medical, incorporating the world-renowned hyper-realistic training simulations into our portfolio of training programs around the world, making cleft surgery training both safer and less costly. In 2021, Smile Train and BioDigital launched a mobile app version of the award-winning Smile Train Virtual Surgery Simulator. This mobile app, which features unprecedented offline accessibility, provides multilingual, interactive 3D training on surgical procedures to supplement hands-on training for surgeons at every stage of their career and skills development. The same year, Smile Train also launched the Smile Finder app, a patient awareness and mobilization app. The Smile Finder helps patients find Smile Train supported cleft centers and provides vital information about treatment options. This tool provides essential awareness and mobilization training for caregivers, social workers, healthcare providers, and other nonprofit organizations. Over the coming years, Smile Train will scale these programs and resources to bring training and education to cleft care providers around the globe, because we know that behind every smile, there's a team of healthcare professionals who made it happen. Thank you.
to start. 我看得到吗？好。Now we are going to proceed the last section of our forum. So this is about a complicated and reoperative orthodontic surgery. So we will start from Dr. Xu. Dr. Xu is a senior orthodontic doctor. I think he will be considered the pioneer of computer-aided surgical simulation. He brings this back to Taiwan. Although he now not in our center, but he run a very successful clinical practice. So we are so happy to have him here to share his experience and beautiful cases. Please.
Good afternoon, ladies and gentlemen. So about redo OGS, today I'm going to focus on 3 simple questions: why, when, and how. Number 1 question: why? Why do we need to redo OGS? And usually, the occlusion is not good, or the profile is not satisfied by the patient. But there's something more, so I put a question mark here, and I will reveal it and discuss later. Second question: when should we redo OGS? And theoretically, ASAP, as soon as possible, is the best policy, because you can imagine the bone is not healed and the screw plates are not embedded in bone. So redo OGS requires no osteotomy at all. So it's much easier as compared to, imagine if you redo OGS 1 year after the first one. However, that's not always the case. So I also put a question mark here, and I will reveal it and discuss later. About how to redo OGS, it involves many aspects, but I want to just focus on which jaw to reoperate: maxilla, mandible, or both. And my answer is it depends. So the following, I'm going to show you a couple cases to have a further discussion. This young lady, facial asymmetry, skeletal class 3, anterior close by and midline off, and a little bit anterior open bites. So we did OGS to fix all her problems. So you can see top is before and bottom is after. So the profile improvement is great in terms of symmetry and lateral profile. However, there was anterior open bite right after surgery as compared to before. You can see the midline has been corrected, but still anterior open bite by 2 millimeters. So I'm sorry for this. This is actually a video, but I transformed my Keynote file into the PDF. So you can just see the combing CT of the patient. So okay, why do we need to redo OGS because of the occlusion? Because the patient was referred by an orthodontist who was at a local dental clinic. So in order to make the orthodontist's life much easier after her OGS, after the patient's OGS, we decided to redo OGS to fix the occlusion. Actually, the profile is quite okay. So we should redo the OGS as soon as possible, as shown here. And how to redo OGS when it comes to whether maxilla or mandible, we need to consider all those factors, like number 1, the relapse pattern. And it looks like it was very likely to be the mandible was not in the correct position, maybe because of the occlusal interference, functional shift, or even the condyle positioning issue. The relapse pattern should be, it could be the mandible. And then we need to think about if we redo the surgery, then how about the amount and direction of the surgical movement? In this case, it will be only like 1 millimeter AP and vertical. So either maxilla or mandible is okay for redo OGS. And she has no specific profile needs. And also when it comes to predictability and stability of the OGS of the surgery, actually, I think the maxilla will be a little bit better as compared to mandible. And the last one is the surgeon's preference. The surgeon prefer to do mandible. So we did mandible for the redo OGS. So this is in the operation. This is before and after, before and after. So in seconds, the surgeon can fix that anterior open bite. And let me tell you, if the orthodontist want to fix that 2 millimeter anterior open bite, it takes at least months. So this is right after the surgery. You can see the occlusion, and after a period of post-surgical orthodontics, you can see the case has been finished perfectly, the occlusion and also the profile, the symmetry. So in this case, why we need to redo OGS? Because we want to fix the occlusion, and we redo OGS as soon as possible, and we did mandible only. Another young lady, facial asymmetry and midline off. So we did OGS to fix his skeletal problem as well as the occlusion. So this is surgical simulation before and after, before and after. And again, there was a post-surgical open bite. And there's something more. You can see the frontal profile. It was a little bit weird. So we look into the combing CT, and you can see the skeleton is looked like this. So we did a superimposition in between the before, plan, and after to try to figure out what was happening. So the actual outcome is somewhere in between the before and planned. So let me show you here. This is before actual outcome and after before actual outcome and plan. So the actual outcome is somewhere in between the before and plan. So it was very likely to be the immediate relapse after the OGS. So why we need to redo OGS? That is because the occlusion is not good, the profile is not good as well. And when should we redo the OGS? Instead of ASAP, we'd like to wait for a period of time for the soft tissue adaptation. And how to redo the OGS, the maxilla and mandible, because there are problems on both upper and lower jaw. So we plan to redo the OGS with double jaw surgery. And when we wait for the soft tissue adaptation, actually I did orthodontics to upright the upper incisors and close the anterior open bite. And then the second OGS is to fix the upper dental midline, the mandible deviation, and the chin deviation. And you can see this is the frontal profile right after the second OGS, and you can make a comparison as to the first time OGS. And after a period of post-surgical orthodontics, so you can see this is the final occlusion as compared to the first time OGS, and this is the final frontal profile as compared to the first time OGS. It's much better, especially as compared to the initial condition. So in this case, why we need to redo OGS? That is because we want to fix the occlusion and profile both. But instead of redo the surgery right away, we try to wait for soft tissue adaptation, and then we did double jaw surgery. So in this case, I tried to figure out that the big skeletal, the huge skeletal discrepancy could result in relapse. And in that situation, we don't do reduce OGS right away. Instead, we wait for a period of time. So let me show you another case. This is a skeletal class 3 mid-phase retrusion and prognathic mandible. And when we look into the occlusion, you can see a big anterior crossbite with minus 20 millimeter and overjet. And in front of you, you can see just mild asymmetry. So in this case, we do double jaw surgery to advance the maxilla 3 millimeters and set back the mandible 16 millimeters. Let me say again, we set back the mandible 16 millimeters to fix the occlusion as well as the profile. So right before the OGS, you can see the comparison between the before and after. You can see very good profile improvement after the OGS. But when we look into the skeleton and the occlusion, you can see still anterior crossbite, which is 2 weeks after the OGS. Okay. So again, why we need to redo OGS in this case? Because actually the profile is okay. So we want to fix the occlusion. And then instead of redo OGS ASAP, we try to wait a period of time and try to wait for the soft tissue adaptation. And then about how to redo OGS when it comes to which jaw to reoperate, maxilla or mandible, we first make a supine position, try to figure out what was happening there. So this is our plan and this is the actual outcome. See again, this is our plan and actual outcome. So you can see the actual outcome, the mandible was positioned forward as our plans. Let me show you different view to double check. This is for upper jaw, plan and actual outcome. This is plan, this is actual outcome, plan and actual outcome. So you can see that the maxilla is right in the same AP position. But when we look onto the lower jaw, it's totally different story. This is our planned actual outcome, planned actual outcome. So the actual outcome, the mandible was positioned forward as compared to our planned. So so about the relapse pattern, it should be mandible. The mandible went forward as compared to our plan. And then about the surgical movement, we want to see if we want to redo OGS, if with one jaw, we either set back the mandible 5 millimeters or we advance the maxilla 5 millimeters. But when we think about the profile, advanced maxilla 5 millimeters is not that adequate. Maybe some deteriorate effect on the nose or the mid-face, and also when it goes to predictability and stability of the surgery, if we advance the maxilla 5 millimeters in reduced surgery, remember in the first OGS, we have advanced the maxilla 3 millimeters. So advance the maxilla 5 millimeters more, it equals to 8 millimeters maxilla advance. That will be too much and the stability will be very questionable. So when it goes to surgical movement, profile needs, and predictability, stability, we prefer to do the mandible. And the surgeon also prefer to do the mandible. So in this case, we want to redo OGS because of the occlusion. We want to fix the occlusion. And instead of redo OGS ASAP, we try to wait for soft tissue adaptation. So we will redo mandible only. And if you have question about why do we really need to wait for soft tissue adaptation, let me show you an extreme case for your reference. So this is an anterior open bite about 6 millimeter. And this is the same case, anterior cross bite about minus 20 millimeters over jet. So it's actually a big class 3, big open bite, and it's an extreme, very severe skeletal discrepancy. So I believe you have no surprise that right after the surgery, you can expect an edge to edge, even an anterior cross-bite occlusion like this. And you can see just like this, edge to edge occlusion. And this is post-op 1 month, post-op 2 months. You can see the occlusion, the buds kept opening. So we had no way but did redo surgery right away, even put the screws, rubber bands, and the wires to fix the occlusion, but the bite kept opening. And then I can only finish the case like this. And you can see as compared to the before, actually we did fix the problem of the anterior crossbite by 20 millimeters, but still anterior open bite there. So here I want everybody to think about one thing, that if we redo the OGS at this time point, just like we treat a fresh case of just anterior open bite, no anterior crossbite by 20 millimeters, that then after the surgery, we may encounter much less soft tissue stress, and that decreases the possibility of relapse. So that's why I suggest to wait for soft tissue adaptation before redo OGS. Okay, another case. This is a gentleman, skeletal class 3 mid-face retrusion and prognostic mandible. And when we look into the occlusion, there's only about 5 millimeter over minus over jet, and mild asymmetry in frontal profile. So this is the occlusion, a little bit open bite, anterior crossbite about 5 millimeters, and a little bit crowded. So after pre-surgical alignment, then we do double jaw surgery to fix the occlusion, also advance the maxilla, set back the mandible, try to correct his problems. And this is the occlusion after the surgery. It was very good, and you can see the profile change before and after. So you can see very good profile change in between before and after. But you know what? The patient didn't like the profile. I mean, after the OGS, this profile at all. The patient did not like the profile at all, and I have evidence to show you why he didn't like the profile. Because he emailed me, he wrote me emails, about 29 emails. Actually, it's back and forth to talk about his profile after the surgery. So why we need to redo OGS in this case? The occlusion is good, the problem is the profile. So we want to fix the profile. And when should we redo OGS? Instead of ASAP, we again try to wait a period of time to, number one, confirm his needs. Number two, try to lower down his expectation. And number three, let him be mentally prepared for the second surgery, even though he was the one asking for the redo OGS. And how to redo OGS? Because the occlusion is good and he was asking to set back the mandible more, so we need to do double jaw surgery with clockwise rotation of the MMC to advance the maxilla 1.5 millimeter and set back the mandible 6.8 millimeters. Those magic numbers comes from the discussion between me, surgeon, and the patient. So this is at finish. I finished the case, fit perfectly, midline arm, very good alignment, very good, excellent class 1 occlusion. And this is the profile change in between the second OGS and the first OGS. Yes, there's a little bit difference, and the patient like this profile. How do I know that? Because last month, around Mid-Autumn Festival, he came back to my clinic and bring me 2 boxes of mooncake. So I suppose he liked the profile now, and he feels happy. Okay. So in this case, to redo surgery is to fix the profile according to patient's needs And instead of redo OGS ASAP, we wait for a period for actually for him to do mentally prepared, and we do double jaw surgery. Another case, a gentleman came with the occlusion like this. I will say the occlusion was quite okay, but you can see a missing canine on the left. So the upper arch bone was asymmetric. And then when we look into his combing CT, and you can see the profile and the skeleton like this. And yes, this is his initial combing CT. And yes, he had done orthodontic surgery before. He had done orthodontic surgery before in another country. But let me show you the profile in this way. Okay, but still a little bit, still he was not satisfied with the profile with a little bit retrusion of the lower third of the face. So he decided to have another OGS. Okay. So in frontal view, it's a little bit just mild asymmetry. So to us, actually it's a fresh case, but actually we kind of redo the OGS. So the plan was to take out one premolar on the right and with two-piece level one, try to establish a symmetrical upper arch form. And then we try to advance the mandible as well as the chin, try to increase the fullness of his lower thirds. So this is the first time OGS. This is the second time OGS. And you can see the profile difference. We increase the fullness of the lower third as well as the chin projection. But you know what? The patient didn't like the profile at all after the second OGS. Again, I have evidence to show you why he didn't like the profile, because he wrote me 143 emails back and forth to complain about the profile, even with some emotional words. So actually, the surgeon tried to did some minor approach like graft to improve the profile, but the patient just was not satisfied. So in the end, the patient went to another surgeon to redo the OGS again. So this is the second time OGS, and we did the second time, and another surgeon did the third time OGS for this patient. So as you can see, this is a clockwise rotation of the MMC to set back the mandible, decrease the projection of the chin. So you can see the comparison of the second time and third time OGS, the profile difference. And you can see the same person, 3 different profile, 3 different screw plate system, 3 different surgeons, but the same complaint, which is the profile is bad. Okay, so why redo the OGS? I don't think it's occlusion, and I don't think it's profile. I think it's mental issue, and it's really an important thing. So when should we redo OGS? In my opinion, instead of redo the OGS ASAP, I will say never touch the patient. Never ever. Okay. And the worst is, as I know, he was still searching for another OGS to change his profile. So sad story. So let me show you another funny story to balance this. This gentleman was referred to me last year, and his chief complaint was, as you can see, the prognostic mandible, long face, and the gummy smile. But actually, the occlusion is quite okay, in my opinion. And as a case of OGS, this is a simple case, right? No, to me, this is a big problem. Why? Because this patient was referred to me last year, but he was my patient 15 years ago. So ridiculous, right? So in this case, I even made the slides for him to talk about surgery first orthodontic approach with BSSO setback, genioplasty of vertical reduction. So we can have profile improvement in the beginning of the treatment. Patient had satisfactory profile change. Patient has satisfactory profile change. It looks like ridiculous right now. 6 weeks after the treatment began. So and you can see right after surgery, big overjet, but we can fix everything in 7 months. That's the power of the surgery first. But the patient came to me last year again. So the occlusion was good. And the only concern is about the class 3, the prognostic mandible, the long face, the gummy smile. So we redo the OGS with double jaw surgery, clockwise rotation of the maxilla and the mandible. Try to set back the mandible and advance the maxilla a little bit and try to impact the MMC. So in order to improve the gummy smile as well as the long face. So this is before and this is after the second time OGS. So you can see the profile change before and after, and you can see the difference between these two. Okay. I know the time is running out, but I want to have a taste as a conclusion. So I want to present a case. So everybody try to figure out your answer about why, when, and how, okay? So this gentleman, facial asymmetry, and because of the facial asymmetry, the orthodontic treatment has been done over 7 years. And he came to us because of the occlusion. He wanted to fix that occlusion because the occlusion cannot be perfectly fixed because of the asymmetry. So we did OGS for him to straighten the skeleton. But then when we look into the occlusion, it's anterior open bites. Okay, so why should we redo OGS? When should we redo OGS? How do we redo OGS? I think you have your own answer, okay? So let me reveal the answer. If your answer is why, because of the occlusion, when, as soon as possible, and how mandible should be the one, then congratulations, you have the good answers, but that doesn't matches mine. I don't have those answers because I did post-surgical salvage orthodontics for this one. So you can see without redo OGS, I fixed the occlusion like this. Perfect midline on class 1 solid occlusion. Another case, facial asymmetry, anterior open bite. So we did OGS and there was anterior open bite right after surgery. So again, I did post-surgical salvage orthodontics to fix the occlusion without any redo OGS. So I can finish the case like this. Okay, midline on, class 1 solid occlusion. Again, facial asymmetry, midline off, and we did OGS to fix all those problems. And after the surgery, the symmetry gets better, but there's anterior open by 5 millimeters, anterior overjet 5 millimeters. Again, I did post-surgical salvage orthodontics to fix the occlusion. Gradually, the occlusion fixed without any redo OGS. So I can finish the occlusion like this, midline on, class 1 solid occlusion, and a good alignment. And okay, let me do this quick. So in conclusion, why redo OGS? For occlusion, for profile, but please be aware of the mental issue of the patients. And when should we redo OGS? Sometimes as soon as possible, but sometimes we need to wait for, as I mentioned, how to redo OGS. When it comes to reoperate maxilla or mandible, we need to consider those factors, including relapse pattern, surgical movement, profile needs, predictability, stability, and surgeon's preference. And before you decide to redo OGS, please discuss with your orthodontist because maybe he or she can salvage the the bites and gives everybody an easier life after patient's OGS. And that concludes my presentation. Thank you.
My topic is the reoperative orthodontic surgery. So first, I think we need to make a clear definition of redo procedure. Based on Posnick's article, I think we need to divide the so-called redo OGS and take-back OGS. So I think we are all impressed by Dr. Shi's presentation. But we go back to our clinical scenario. Basically, the take-back OGS means that you carry out a procedure for a recognized complication before the osteotomy healing. And this is so-called take-back OGS. So usually you may make a decision and you try to do it as soon as possible. And for my part, I think I will focus on so-called redo orthodontic surgery. So this is an osteotomy that you or reconstruction you do after healing of your primary osteotomies. So basically, it's a kind of a delayed management after primary orthodontic surgery. In the past, I made patient statistics for Professor Chen's surgery first cases. And between year 2010 to year 2016, include around 882 surgery first cases. Here, I write the percentage of redo jury position as almost 2%. But when I go back to the definition of the take-back and redo, I think this is both, including both redo orthodontic and take-back orthodontic surgery. And based on the past series, we have a bit higher than 2% case that require facial skeletal contouring after bone healing. Personally, I started my practice learning from Professor Chen, and currently I accumulate total about 800 cases, and 400, about half, belongs to Professor Chen's team. And our patient is about majority are female patient, and 97% we do two-jaw surgery, and 90% are developmental dental facial cases. And in those 800 cases, there are 7 take-back OGS, but not all of them need jaw reposition. And for reoperative orthodontic cases, currently I have only 9 patient experience. So among the 9 reoperative orthodontic surgery, so first we need to discuss the costs or the reason for reoperation. So only one is poor occlusion, and 8 patients do reoperation because unsatisfactory aesthetics. And 3 of the 9 patients require segmental osteotomy for either maxilla or mandible. And 5 out of 9 cases, the primary procedure was done here in Chang'an Craniofacial Center, and 2 of them, the first is done by myself. And 8 out of 9 require hardware removal simultaneous. So it means that for most of my reoperative cases, hardware removal at the same time is necessary. And for all the cases, we need a two-jaw surgery. First, I show here is the time interval between the reoperative orthodontic and primary orthodontic surgery. There is the shortest reoperation only 4 months after surgery. The second earliest is 6 months after surgery, and the other 7 cases are at least 1 year after surgery, and the longest is 20 years after primary procedure. So here I list several challenges and then present the management about each topic. First is about the timing. I think for any either occlusal or aesthetic problem, based on Dr. Shi's presentation, you know you need to make a decision in between surgeon, patient, and orthodontist about the timing of the operation. But I think basically we should have a so-called complete preoperative preparation. So the orthodontic, the patient's physical and mental status, and the TMJ problem, you should also take into consideration. And a lot of our practice, we do surgery first. So sometimes we will allow either the soft tissue stabilization, adaptation time, or for surgery for some orthodontic alignment time before the reoperation. So how about the bone quality to be good enough? Based on my 9 case experience, for the earliest 4 months after surgery, I feel that the mandible is relatively soft. So it somehow is a bit risky if you do it earlier than 6 months. And so, in my opinion, I think for the bone quality to be good enough, it should be at least 6 months after primary orthodontic surgery. And if you do, I do some literature review, and the largest series goes to Dr. Raffani from Italy and Dr. Posnick from United States. In their practice, they do reoperative OGS for those not treated in their department. So most of the time they do it minimum at least 1 year after the primary procedure. So this is about the timing. And for the hardware issue, I think the best way, of course, is that if the patient would accept another procedure to remove the hardware before we do procedure, it's easier for our surgeon. But for the patient, it's an extra procedure. So currently, my practice, I do it at the same time with redo orthodontic surgery. So based on a Posnick study, if you do the operation, the increased operating time is about 37 minutes. How about if the primary is not done in your hand? Something very difficult is that it's not easy to have a correct screwdriver. Sometimes you can just accept that and then try to remove the plate screw during the surgery. But I need to mention that the possibility of retained intraosseous hardware could be possible, especially for the mandible screws. So later I'm showing 2 cases. So this is case number 5. When he visits me, he is around 38 years old. So he received two-jaw surgery at the age of 18 in another medical center when he was only 18 years old. And there is a recurrent class 3 skeletal and no occlusion. So when he comes to me, you can see the first procedure is a two-jaw surgery with plate screw on maxilla and bicortical screw on the mandible. And the screw was located there for around 20 years. And the upper front teeth you see is mainly prosthesis. And if you look more closer to the plate screw, you will find that actually the first procedure, they may place the screw or place the osteotomy too low, then induce some dental injury. So here is the bicortical screw. So in this time situation, before the procedure, I explained to the patient it could be very possible that I'm not able to take out the bicortical screw. I don't want to waste too much time for this portion. So during surgery, I just use power use saw to cut through the bicortical screw. And actually, I tried, but I only take only 1 or two bicortical screws. So this is the outcome before and after. So you can see both sides. Maybe I only just take one, and then I fail to take out the other two screws there. And from the position of a screw, you can see the distal segment is setting back in the reoperation. And this is the profile before and after the reoperation. And then for this case, I make a new the one cut. So I'll explain something about this later. So the next will be where to put your osteotomy. There are some tricks that before your reoperation, I will suggest that you do a 3D planning, and then as a surgeon, you check the CT or 3D image carefully to understand the anatomy. And later I'm going to show several cases. And I think the freedom to design a osteotomy knife for the mandible, I believe it is fine. Basically, you can always design a new osteotomy knife for the mandible, because mandible have a good bone stock and you can cut whatever you want. But for the maxilla, maybe not. So this is a case number 9. This is before what she received for her primary procedure. So it's a mild bimaxillary protrusion, class 1 bimaxillary protrusion. She received procedure in Korea by doing a maxilla setback intrusion, and mandible is a way of subcondylar osteotomy and IMF to allow the bone healing. So in this situation, the first time I'm not very sure that if I can perform the surgery for her. And after evaluation, we determine the upper lower segmental for both maxilla and mandible advancement to improve her problem. So this is from my simulation profile that I can see clearly the regional anatomy of mandible from inner side. So if you have a 3D image, you reconstruct it with adequate software, you can see whether is it feasible to redo the procedure. So I still do the procedure. Here we can still see the lingula. So I think I just remind myself, although especially for the left side, the bone seems to be quite inadequate. But during surgery, I think I try to identify the lingula and carefully cut a bit behind that area. I can still achieve mandible sagittal split osteotomy. So back to the case number 5 here, I'm going to say that the first osteotomy cut actually is very low, and it's already 18 years after the primary procedure. And for this male patient, the bone quality is good. So after taking out the previous plate and screw, I can place the osteotomy 5 millimeters higher than original, and then I can still do a safe fixation for this guy. So for this male patient, it's fine. The bone quality, maxilla bone quality is good. I can move up and redo it. And this is case number 6. She is, I'm not very sure, but I believe the first time she is originally a skeletal class 3, and she received maxilla procedure, and mandible seems to be in IVRO and osseous genioplasty. So for her, this is the situation when she comes to me. And actually, the similar problem still appears, that you see the fixation here. So actually, I don't get the medical record from the first procedure. It could be anterior segmental or maxilla. I'm not very sure, because the fixation is quite different from ours, and you see possibly the screw hole already injured the teeth during the first procedure. Initially, we plan a procedure also that we extract number of upper premolar both sides, and we want to do the compensation for the upper. But she a bit in a hurry to get married, so we determined to shorten the preoperative preparation that we changed to a upper segmental osteotomy and sagittal split mandible setback. So this is the before and after, and for her, it really makes me take much longer time. So this is the situation actually after the maxillary reposition. The original osteotomy line is this one. This is she is 5 years after the primary procedure. So I tried to cut again at least 5 millimeters higher than the original position, because I believe the first osteotomy line is located too low, and the dental root is very dangerous. But for her, when I cut here and down fracture, because the previous osteotomy doesn't heal very well, so end up this vertical bone volume turned out to be lost, and this become a mobile bone segment. So I'm not able to really fix in this portion, because although I plan a higher osteotomy, but I still need to fix back to the original maxilla cut position. So for her, this is an answer that sometimes you're not able to change your maxilla osteotomy, even it's 5 years after primary procedure. But because it's a mandible setback, we get a lot of bone graft. So after temporary after maxilla region fixation, we can put on all the bone graft from the mandible to achieve osteosynthesis, and hopefully the bone healing will be fine. So this is a failed attempt to move the Level 1 osteotomy. So how about it? So from several cases, we know that sometimes you still need some bone graft, especially if you have a bone defect from primary procedure. And in our practice, I think I will suggest several places. The most common is the lingual cortex of mandible angle. So because we incorporate Hansa type osteotomy, so I think this is something we keep emphasizing during our forum. And then the coronoid process is also a possible source. You can use a medial portion, the lingual portion, the partial thickness, or you can, if you need more, you can basically harvest the full thickness coronoid process. And for the case who do mandible setback for procedure, you have an extra source of bone graft. Of course, if the bone graft from mandible is not enough, you should consider from distant side, calvarium, rib, ilium, or tibia. But till now, I don't have that type of experience. For the indication and patient evaluation, I think for all medical field is the same. We should have a correct diagnosis and then have a good management of all our cases. So for this portion, I will really suggest that you take a look at the Dr. Renneke's article, Reoperative Orthodontic Surgery, year 2011. For the occlusion problem, you need to consider either neuromuscular, poor, when you do secondary procedures, try to release the muscle as much as possible. So this is also something that we keep emphasizing also in the field of MMA for OSA patient. And for scar tissue, of course, is a problem. Then for maxilla expansion, consider a proper spring. And sometimes, if you're really concerned about something you maximize your practice, you cannot achieve, you can consider to design some overcorrection. And another way is not doing move the bone at one procedure. You can do SARP or distraction osteogenesis. Intermaxillary fixation is some way that some surgeons will prefer. But here we try, most of the time, we try not put in intermaxillary fixation. So in our practice, only for the aesthetic fracture, but if you are not able to rigidly fix the mandible, maybe we will do intermaxillary fixation, but we do not really consider this is a long-term way to overcome the muscle or scar problem. So for the continuous growth, for classic patient, maybe you just wait here for maturity, or you aggressively do condylectomy. For the condyle reposition, so either it's a disc dislocation, you do disc replacement, or for end stage joint problem, you consider a total joint replacement. So this will be the topic for the next speaker, Dr. Lin. And then the second, actually, based on my series, the most of patients doing we do OGS for aesthetic reason. So I think I need to echo the presentation of Dr. Xu, that he presented that case with BDD, similar to BDD. So we should have to know listen to the patient first, to know the subjective perception of problem and the patient's expectation to the secondary procedure. And then, as a surgeon or orthodontic, we do our objective evaluation. So should be a systematic soft tissue, skeleton, and based on different anatomic units, and based on the 6 degree of freedom. I don't list the rotations here, but basically is for every anatomic unit, you need to consider what is the problem. So for the last thing that I think Dr. Rafani, he presented the largest series, TNL. So this is in year 2018, he published. And based on his practice, he collected about 230 cases. He do acquire a clear preoperative evaluation. For all the reoperative cases, all the patients need to see a psychologist. And he will compare the aesthetic complaints with the objective aesthetic analysis with the patient. So first, you try to exclude those with psychotic tendency. You exclude those with BDD, body dysmorphic disorder. And if the patient have unrealistically high expectation for your secondary procedure, maybe you exclude them. So after exclude all the patients' mental situation, then he get about 179 patients. But out of them, if you provide a jaw procedure, maybe the patient won't really agree. So finally, in his series, he do 70 redo procedures. But we learned something that from here, we know psychologist helps to help us to check if the patient is a body dysmorphic dysfunction or psychologically unstable situation. And then we can only operate on those whose complaint match our objective evaluation. And those who have realistic expectation, they have normal psychological status. And of course, they need to willing to accept the second major procedure. And of course, we learn from Professor Zhang that some adjunctive procedures, Botox, filler, fat injection, and some other procedure could help to achieve the best aesthetic outcome. You should also consider before you go into the reoperative orthodontic surgery. For TMJ problem, basically for me is quite, it's not simple, of course, but I think we need to make sure the TMJ condition is stabilized before the two-jaw surgery. And I will just give some simple questions if there is pain limitation of the TMJ and the mouth opening. And then if any doubt, we just refer to our TMJ specialist. So I think that's about the time to let Dr. Lin to talk about his experience about TMJ. So here the take-home messages. The suggested timing, most of the time should be at least 12 hours. Complete removal of mandible, however, could not be guaranteed before the surgery. The freedom of redo maxillary furrow is sometimes limited, and careful patient evaluation, including TMJ and psychological problem, is recommended. Thank you. we will have Dr. Lin. Dr. Lin is work in our own department, and now if any TMJ problem, we refer the case to Dr. Lin. So we are so happy to have him here to share his experience in this field.
Okay, thank you for Dr. Yao's introduction. Hello everyone, I'm Arthur Lin. It's my great honor to be here today to share my clinical experience in TMJ, arthroscopic surgery for patients with dental visual deformity and the internal derangement. As far as we know, most of the treatment of TMJ are conservative. Some clinicians even consider that TMJ surgery is useless. However, TMJ surgery is still necessary for some TMJ pathologic patients when conservative treatment fails. Internal derangement is defined as a displacement of the disc from its normal functional relationship. Because the etiology of TMD is very complex, the disc position does not always correspond to the clinical symptom and signs. The study showed that the disc displacement was observed in 33% of the asymptomatic volunteers, and therefore 16% of symptomatic patients did not show the disc displacement from the MRI. The pathogenesis of a TMJ internal derangement comes from the intermittent joint overloading and the increased friction between the disc and the fossa. On continuous clinching, the disc is easily dislocated forward and anteriorly displaced. The vehicle staging system provides a guide for the treatment of internal derangement. This system includes 5 stages from the stage 1, being a painless disc displacement with reduction, and to stage 5, being the advanced disc displacement with severe degenerative change of condyle. However, the staging system does not reflect the cause of TMJ damage. If we do not understand the underlying cause, and the treatment will fail. This study evaluated 104 patients with internal derangement based on the cause. After a surgical intervention, the results showed that 23% of cases were misdiagnosis. It revealed that the correct diagnosis of TMD is very difficult but important, and therefore we have to choose the treatment option as less invasive as possible. A key principle to manage the internal derangement is to reduce the pain, improve joint function, and stop the destructive process. Based on the principle, we often arrange a 2 or 3 week regimen by the conservative treatment first. If the symptoms begin to resolve, then non-surgical treatment is continued. However, if the symptoms persist, the minimal invasive surgery is often required. The treatment of internal derangement can be divided into non-surgical and surgical options. In non-surgical options are including the patient education, medications, and the physical therapy and the occlusal sling therapy. And in surgical options are including the minimal invasive surgery, such as arthrocentesis and arthroscopic surgery, and open TMJ surgery, and the TJR. I will focus on the efficiency of arthroscopic surgery today. Here we can see the early stage of internal derangement can often be managed with the non-surgical therapy. The more advanced stage are treated with a non-surgical therapy combined with minimal invasive surgery, such as arthroscopic surgery or arthrocentesis. And the late stage, that might be ankylosis with loss of joint space, required open TMJ surgery. And let's take a look. Is there a correlation between the dental visual deformity and the internal derangement? This study was designed to analyze the relationship between the TMJ disc displacement and the skeletal deformity. All the patients were divided into 6 groups based on the MRI according to the increasing severity of TMJ disc displacement. And this study concluded that the disc displacement might be present in patients with various skeletal deformities, regardless of TMJ symptoms. And the patient with a skeletal class 2 and all hyperdivergent deformity have a high possibility of severe disc displacement of TMJ. Another study was to evaluate the incidence of ADD without reduction of the TMJ in patients with dental facial deformity. And the results show the ADD without reduction was more present in skeletal class 2 than class 3. And in skeletal class 3, ADD without reduction was significantly more common in joints with mandibular asymmetry than others. And the ADD without reduction was only observed on the deviated side in both class 3 and class 2 with mandibular asymmetry. This indicated that dental facial morphology is closely associated with anterior distal displacement, and the TM joint is extremely important in the development of the dental facial structures. The animal study was to evaluate the role of articular disc in condyle regeneration. In animal study, there are 15 male rats randomly divided into 5 groups. The first group is control group with normal condyle, and the second group is a condylectomy group, and third group is condylectomy with appliance group, and the fourth group is condylectomy with discectomy group, and last group is a condylectomy, discectomy, and the appliance group. The results show the regeneration of the condyle was only observed in the condylectomy group rather than the condylectomy with discectomy group. In the condylectomy with appliance group, the regeneration of the condyle was even similar to a normal condyle. It has been concluded that the articular disc appears to be crucial in the regeneration of the damaged condyle, suggesting that damage to the articular disc may impact mandibular growth and the regeneration of the condyle. So we use this concept in our teenager patient. This is a 13-year-old boy with complaint of pain over bilateral TM joint. The MRI and the complete CT show the bilateral disc displacement without reduction and the condyle resorption. We try to treat with anterior reposition screen for his TMD first. However, the resorption of bilateral condyle was still active. Then we suggest him to receive the bilateral minimal invasive arthroscopic discopy for improving the TMJ condition. After the surgery, disc reposition was confirmed by MRI, and the condyle regeneration with double contour was noted by complete CT. As you can see, the lateral surface showed a mandibular advancement with wider airway after the bilateral TMJ discopy, and the facial profile was also improved. And let's take a look at, can orthodontic surgery improve the symptoms of internal derangement? There were lots of relative studies. Some studies reported that orthodontic surgery reduced symptoms and signs of TMD because improvement in occlusal stability and the reduced emotional stress. However, other studies show a worsen or non-change in TMD after the orthodontic surgery. The impact of orthodontic surgery on the symptom and sign of TMD has been still controversy, but most of the review articles propose that we should treat the TMD before orthodontic surgery. The most unfavorable result is a severe relapse after orthodontic surgery, especially in patients who receive large amount of mandibular advancement. At present, it is generally known that there are 3 main risk factors for the relapse, including condyle malposition, over-talking by cortical ridge fixation, and the condyle resection. The study was to evaluate the risk factor to condyle resection after orthodontic surgery in MMA. The results show the patient with a higher mandibular plane angle, TMJ dysfunction, and the disc displacement are easy to develop postoperative condyle resection. And this article suggests that the postoperative aggressive condyle resection may be associated with the coexisting TMJ pathological abnormality. And the best way to decrease the risk of postoperative condyle resection is making the correct diagnosis and treating the TMJ issues. And then we will publish this new protocol for prevent the condyle resection by open disc reposition with a MITED anchorage. In his study, the 12 patients with aggressive condyle resection that were treated by disc reposition, and the results show the long-term follow-up demonstrate no relapse, and the 5 of the 6 teenager patients demonstrated postoperative mandibular growth. They also use this concept to evaluate relapse after MMA with counterclockwise rotation. They divided their patients into 3 groups. All the 3 groups received similar MMA and counterclockwise rotation, and in group 1, patients with a normal disc position. And in group 2 and 3, patients both have a disc displacement, but only group 2 received the disc reposition surgery. After the surgery, the relapse was only in group 3, but stable in group 1 and group 2. We can conclude that disc reposition seems to promote a protective function in TMJ pathological patients. In Young's publication, he compared the result in arthroscope discrepancy and open reposition. The group 1 is arthroscope discrepancy and the group 2 is open reposition. And the results show that there are significant improvement in clinical parameter in the two groups. However, improvements occur earlier in arthroscope discrepancy than in open reposition. And he also found that postoperative MRI revealed a higher success rate in arthroscope discrepancy group. And the new bone formation was found more in arthroscope discrepancy group. Therefore, arthroscope may be a better choice for this disc displacement patient with the advantage of faster clinical improvement and recovery, minimal invasiveness, and better contact regeneration. Arthroscopy surgery has a high successful outcome, and it can not only license and lavage epigenetic space, but also for minimal invasive surgery. The surgical technique is divided into 3 levels. In level 1, we use a single puncture for lavage and swab at the 7 point for illumination. In level 2, we use a double puncture for indentation. However, we show a different method for anterior release, including a knife hand instrument, coblation, and home laser. In level 3, we can perform disc reposition with suture. The procedure is also called a discoplasty. Here we can see the disc reposition in the same patient. We can classify the arthroscope discoplasty into the 3 major groups: non-rigid and semi-rigid and the rigid group. The main problem of non-rigid technique is a high rate of relapse over time because the disc is attached to the soft tissue of the face, and therefore the double pass suture might be a better choice. On the other hand, the semi-rigid technique provides more stability, although it's more complex to perform technically. And the rigid technique, which performed with a screw or pins, may injure the fiber cartilage of the condyle because it partly starts out of condyle. So we apply the 2 methods to our TMJ patient to evaluate the efficiency. The non-rigid technique is double pass suture to face, and the semi-rigid technique is double pass suture to external auditory canal, EAC. And basically, there are 2 main steps in the discoplasty. Those are anterior release and the suture. The first step, the anterior release, is the same in both 2 techniques. We will put the scope to the anterior recess and will release the anterior adhesion with a hand instrument. And finally, we will pull the disc back to its normal position. The second step is suture. This is the main difference between the 2 techniques. In non-rigid group, we only grasp 1 time from the medial side of the suture. The needle will directly pull back outside the face. And finally, we suture the stitch into the subcutaneous tissue of the face. And on the other hand, in semi-rigid type, we grasp twice from the EAC, and we suture the stitch into the subcutaneous tissue of the EAC. We analyze our 13 patients by the 2 methods, and we can see the 2 surgical procedures are slightly different in possibility facial appearance, and there will be less wound on the face in the semi-rigid technique. And both of the 2 methods show the substantial improvement in the clinical symptoms, like mouth opening and the pain decrease, and no significant difference of outcome between the 2 methods. And we also find that the semi-rigid technique has a higher success rate than non-rigid technique in disc reposition. Comparing the 2 methods, both techniques are equally good for improving the clinical symptoms, but semi-rigid technique is better for the stability of the disc reposition. We believe the reason for the difference is that the direction of the suture can be adjusted, and the subcutaneous tissue anterior to EAC is thicker in the semi-rigid technique. Now I will share my 2 cases with different methods and compare the result. Let's see the first case. This is a 27-year-old female with facial asymmetry and TMD. She wanted to treat her dental-facial deformity and also complain about pain and the limit mouth opening of right TMJ for several years. The MMO is 28 mm and the pain score is 5, with right TMJ clinking. And the SEV show the facial asymmetry with right upward occlusal plane can and the chin to right side. And the Polaroid show the right ramus high is shorter than left side. And the bilateral condyle were deformed, but the cortex was intact. The MRI showed the ADD without reduction of the right TM joint. It's compatible with patient symptoms. So we arrange a conservative treatment by anterior reposition screen first. However, the symptoms still persisted. So we suggest the patient receive right TM joint arthroscopic discopathy, and we perform the non-rigid technique to this patient for discal reposition. And after the TMJ treatment, there is no scar on face and no pain in the right TM joint, and the MMO increased to 13.7 millimeter. The post-op MRI showed the improvement of the discal position and the normal condyle movement. However, there are some side effects of arthroscopic discopathy. We can see the malocclusion, early posterior open bite, and the low dental midline shift to left side, and the anterior open bite in our case. The reason can be the right condyle move downward and forward, and then cause the change of mandibular position after the surgery. And our result is compatible with Larry Rivers' publication. In his study, discal reposition will result in the opposite direction of the condyle and decrease the joint loading and improve the stability of the condyle. And compare initial to 3 months after the arthroscopic discopathy, we can see a little bone opposition in the surface of condyle. Then she went into orthodontic preparation with leveling and dental decompensation. Compare initial to after orthodontic treatment for 7 months. It is interesting that the partial surface of condyle seems to become resorption. And we can see the symptom and sign improve after she received right TM joint discopathy. And there is no recurrent symptom before orthodontic surgery. The surgical plan was level 1, the BSSL osteotomy with the counterclockwise low rotation for facial canting. And the ANC clockwise rotation and the laminoplasty advancement for facial profile. The photo shows the symmetric face, pleasant smile, and the improved profile. The panorama shows the before and after orthodontic surgery. Before and after, and before and after. And 3D shows the before and after orthodontic surgery. Before and after, before and after. And compare initial to 3 months after orthodontic surgery, we can see more resorption in the surface of condyle. And now she is ongoing orthodontic treatment. The occlusion is stable. Let's see another case. This is an 18 years old female with facial asymmetry and TMD. She wanted to treat her dental facial deformity and also compare bottom of left TM joint for several years. And the MMO is 14.3 millimeter. And the pain score is 7 with left TM joint clinking. The SEV show the facial asymmetry with left upward occlusal plane can and the chin to left side. The panorama show the deformity of left condyle head, and the left ramus high is shorter than right side. The MRI show the ADD without reduction of left TM joint. It's also compatible with the patient's symptoms. So we suggest the patient to receive the conservative treatment by anterior reposition screen first. However, the symptoms still persisted. So we suggest the patient to receive the left side arthroscopic discopathy. In this case, we use the semi-rigid technique. After TMJ treatment, there is no scar on face and no pain or clinking sound in the left TM joint, and the MMO increased to 13.7 millimeter. And the post-op MRI showed the disc was successfully repositioned with normal condyle movement. And the side effects are the same as we mentioned in the last case. We can see the left condyle move downward and forward, and cause the mouth occlusion and the lower dental midline shift to the right side. Compare initial to 3 months after discal reposition, bone opposition was noted in the surface of condyle. And then she went into orthodontic preparation with leveling and dental decompensation. Compare initial to 9 months after orthodontic treatment, we can see more bone opposition in the whole surface of condyle. And we can also see the symptom and sign are improved after she received left TMJ discopathy. And until 9 months of orthodontic treatment, there was still no recurrent symptom. Then she was prepared to orthodontic surgery. The surgery plan was level 1 BSSO osteotomy with clockwise rotation for facial painting, NAC clockwise rotation, and then genoplasty advancement for facial profile. The photo shows the symmetric face, pleasant smile, and the improved profile. And the panoram shows the before and after of the surgery. Before and after. Before and after. And the 3D shows the before and after of the surgery. Before and after. Before and after. And compare initial 2-3 months after of surgery, we can see still mild bone resorption in the superior surface of the condyle. Now she is ongoing orthodontic treatment. The occlusion is still stable. Comparing the two techniques in our patient, we think that the semi-rigid technique seems to have more effective in TMJ stability because we can find the non-rigid case have more condyle resorption both after orthodontic and orthodontic surgery. So based on my personal experience, the evaluation of the TMJ problem before the orthodontic surgery is very important. The symptom and the sign of patients in TMJ internal duration must be treated effectively to avoid the subsequent problem during the orthodontic surgery and the orthodontic treatment. And for the TMJ internal duration patient who fail to conservative treatment, minimal invasive treatment is the first priority. And discal reposition can promote the structural stability of the condyle and may reduce the risk of condyle resorption during the orthodontic treatment and the orthodontic surgery. And both methods can improve the patient's clinical symptoms and signs. However, the semi-rigid technique has more effective reposition than non-rigid. And then, finally, the comprehensive treatment of TMJ internal duration combined with dental facial deformity is very complex. Because the causes of TMD are often multifactorial, we should pay more attention for diagnosis before treatment. In the future, we still need more study to find out the effectiveness of treatment. And that's all my presentation today. Thank you very much.
Okay, hello everybody. First, I would like to thank everybody who is still online with us. This is the last topic, and it's a great honor to be the last speaker. So my topic will be the revision surgeries after what we talked previously, talked about MMA in obstructive sleep apnea patient. As we talk about the MMA, it can enlarge the pharyngeal space by expanding the skeletal framework. So the soft tissue pharyngeal structure and tongue is able to stay in the enlarged framework. And we reduce the pharyngeal collapsibility during the negative pressure inspiration. And Professor Casey Lee had some first recommendation for OSA patient as MMA is if the moderate or severe OSA without significant pharyngeal tissue redundancy. Or the second is the significant maxillomandibular deficiency. And the third one is a young patient who require long-term OSA resolution. That can be the first choice of management of these patients. However, when we look back deeply into the effectiveness of MMA into the meta-analysis, we can see that although the surgical successful rate can be high as 86%, and the cure rate can be like 40%. However, there must be 10 to 20% of OSA cases which the ASI cannot be successfully reduced after surgery. So the incomplete remission must have the reason. It's possibly caused by relapse, and the relapse may due to the PSG evaluation. When you do the PSG evaluation, you found the AHI still go up, or they have recurrent symptoms. So the long-term, we're gonna see some patients, they have the long-term follow-up and the recurrent symptoms, and talk about the strategy and management of these patients. We're gonna see two cases of our center. The first one is a 36-year-old man who first come to because of snoring with daytime sleepiness. He is a non-smoker. He had received UPPP at other center and some nostril surgery for his OSA symptoms. He preoperatively, his BMI of 23 is relatively not obesity, and RDI was 46. The lower saturation at that time is 69%. He has class 2 malocclusion with severe overjet, and at preoperatively, his pharyngeal airway space was 5 millimeters. So this patient received the operation in 2004. He's received level 1 osteotomy with Wasserman setback for the anterior segment. And for the mandible, it was advanced about 7 millimeter, genioplasty advanced 4 millimeter, and elongation for like 6 millimeter. So after the surgery, looking at the cephalogram, the pharyngeal distance, pharyngeal airway space distance increased successfully, but this is immediate post-op. So this is post-op 1 month, the frontal view and the lateral view. So look at both the neck position become more straight, and the chin is successfully advanced. However, we can see the follow-up of this patient. The BMI of this patient didn't really increase. He didn't get very fat, but RDI of this patient slightly go up after 1 year, and 4 years after the first OGS, his AHI goes up to 55 to the severe OSA, and lower saturation also goes down. So the recurrent symptom as daytime sleepiness and snore was also found by this patient. Before we evaluated this patient again, and before we gave him another treatment, you can see the cephalogram, the narrowest pharyngeal airway space go back to like 2 to 3 millimeter, not like the first when he just did the first OGS. So we did another OGS for him. So this time it's also a 2-jaw surgery. So total complex was advanced 5 millimeter on the maxilla. So this is the evaluation about the cephalogram. The PAS over the Vallum and Tom preoperatively was 2.5 and 4.2 millimeter. After the surgery, the Vallum variance can go up to 7.8 millimeter, and after retrogressal can up to 12.6 millimeter. And A point advancement is 9.8 millimeter, and B point is 16.3 millimeter. This was 6 months after his second MMA. And after, when he debound, you can see that the pharyngeal airway space keep very stable number, as the 7 is the narrowest and 13 is the tongue base. And A point and B point amendments together slightly relapse, but less than 2 millimeter. The long-term follow-up of this patient, you can see that from after the second MMA, from 4 months, 1 year, 3 year, 5 year, longest to 7 years, the AHY can be completely normal as a normal variance and go just down like 0.4. And the lower saturation is also very good, 92%. So this case, we're going to discuss this case later, but we can see that after the adequate advancement of the MNC, the AHI can be very stable and the symptom won't go out again. So this is the case follow-up at 2 years, 5 months. This is the lateral view of the photo. And this is 4 years follow-up. he didn't get fat, and the chain get very good stable position of this patient. The second case is another patient who's very suitable for MMA treatment. He's 33 years old. The BMI before surgery is 22.9. The tonsil grade is grade 1. MMP was 3, so oral cavity is very crowded. He has septal deviation, so he received septoplasty before this surgery. He is not a smoker. Preoperatively, the cephalogram showed a very protruding. The PSG before surgery, his HI was 23. Actually, it's not very high. It's not going to moderate OSA. The lower saturation was 80%, but his symptoms are very strong. His ESS score was 14. It's very sleepy at the daytime. This first cephalogram analysis showed the PS, the valence was 4.5 millimeter, and the tongue was 9.2. His SMB was very small, as 68 angle, 68 degree. So this is pre-op cephalogram. He received SMMRI for this patient. His because the upper teeth, anterior teeth is very proclined, so he received the segmental of the maxilla. So postoperatively, the cephalogram, we can see that the PAS at the valence can goes up to 10.5 millimeter, and 8-point advancement because of the segmental is only 1.6, but the B point can goes up to 18.8 millimeter. This is the patient post-op 3 months. The frontal view, you can see the chain completely go out, and the lateral view of this patient. However, during the follow-up, the 4 months of the follow-up is really good. HI go down to 1.7. His ESS, his sleeping score is only 5. But about 1.3 years, his BMI didn't go up, but the AHI slightly go up to moderate. And the ES, he is subjectively think he's very sleepy at the daytime. So we check about the cephalogram of this patient. The airway of that dimension is really good, got more than 10 millimeter. So when we see that some of the soft tissue over the airway, this what I choose in this area is of the uvula is relatively very large. So we decided to do a uvula reduction surgery. So this is the soft tissue surgery of the pharynx. But after the surgery, you can see clearly on the cephalogram. It's this occupied the space, the soft tissue become less. The PSG data follow up this patient is also really good. From 1 year to 5 years and 6 years and 7 years, the AHI go down to as normal level. But however, you can see in the 7 years, it still slightly goes up. This possibly due to the aging condition, and he's a little bit getting BMI a little go up too. But the sleeping score, ES score, can be very stable. So this is the 2 years follow-up cephalogram. The A point and B point keep stable, and PAS is also can get very good dimension, didn't get any relapse. This is 9 years follow-up. Cephalogram is also stable. So we can discussion about these 2 cases. The amount of advancements also we already discussed in the OSA section this morning. The maxilla advancement previously think is a very important factor for the successful of MMA treatment. It's because the advancement of the maxilla, the PNS advancement, can keep the velum and velopharyngeal muscle big tension to keep it tight, not able to collapse during our sleep. In the study, we show that 9.5 in the group of the advance of 9.5 millimeter will get better success than 7.9. Even it's just 2 mm difference, it have significant difference from these two groups. So in the past, it's recommend that over 10 mm is will be a good factor for the successful rate. However, in the Asian patients, that over 10 centimeters is not that easy. So this morning we already talked about you can choose. Another thing is using the segmental of the anterior teeth. But the mandibular advancement is advance the tongue and suprahyoid muscle. So, but in the Caucasian data usually show no difference between successful and non-successful group. So you can see in the both group, they can advance about 10 or 11 millimeter. So actually the greater advancement tends to have achieved the better result. That's what we really see in our clinical practice. About the stability of the greater advancement of MMC complex, there's 25 patients. This is 2014 is a study of 25 patients with MMA and junior glasses advancement for OSA patient. They used sabermetric measurements. The result is actually there's a follow-up of 11 months, about 1 year. There's no occlusal change for the skeleton. The A point and B point can keep their position after the surgery. So no correlation between length of follow-up. They found go follow-up longer is no change of sabermetric measurements. Another stability study for the 32 class 2 patients by maxillary surgery, segmental level 1, mandibular advance over 10 millimeter at B point. They found they follow up mostly at 18 months postoperatively. The results showed B point have relapse at 1.3 millimeter, and Pagonian has 1.6 millimeter. So it's about 10% or 15% of relapse. It's also seen in other studies. So actually the skeletal stability for greater advancement didn't really affect the stability of our skeleton. So about this relapse, so what happened to possibly result about skeleton? This is a complex multifactorial phenomenon. So the first thing is the amount of advancement. Greater amount of advancements must have greater relapse, although the relapse is like 10%. And the type of material fixation, but now I think that most of our fixation is really rigid. Another thing, still very important is about the condyle resorption. Just as previous talk, like as Professor Ling said, the condyle must be healthy before the surgery. If the condyle is not healthy, the relapse will goes like 100%. Another thing very important is the soft tissue and muscle tension. So this is because when we get that much advancement, we really need to release the tension will cause the relapse. Because the class 2 patient, the muscle must be relatively short. So about the medial pterygoid, it needs to be totally released for the distal segment. About the long-term follow-up of the MMA, there's the review showed that in 3 studies, 56 OSA cases, mean follow-up 3 years and 7 months. They found it still have 89% success in significant reduction in AHI from 66 to 7.9, and improvement in the lowest saturation to up to 86%. However, these patients, because of the aging and a lot of life quality changing, their BMI usually increase. And these people, because they are Caucasian data, usually their BMI are quite high. They increased from 30 to 32, but actually the AHI didn't really go up. So the soft tissue effect for these long-term follow-up, the first thing is aging. Because of aging, the soft tissue become more sloppy. It's not that good tension is when you are young. And even usually you can see some of the patient have the relapse about usually a female after the menopause, the soft tissue also have more sloppy after menopause. Another thing is the major weight gain. If the patient have a major weight gain, the soft tissue will also become more easy to collapse because of the fat underlying the mucosa. It's not only on the nasopharyngeal space, it's also will on the oropharyngeal space. So this is the a treatment category algorithm for this for RSA treatment produced by Professor Clement Lin. So if we have that RSA, we noted, the first thing we're going to try is check if it's obesity or not. So if it's obesity, we'll go to first, we'll go to the weight reduction or bariatric surgery, and also combine CPAP treatment. If it is not obesity, we'll go to see the Mallampati scale to see the oral cavity space. This space is good, also grade 1 or 2. Oh no, it's Mallampati was 1 or 2, so the space was large enough. Then we'll see the tonsil grade. The tonsil grade is 1 or 2 means it's relatively have good space in the oral cavity. There may be other thinking about these patients why they have OSA. So it may go to nasal obstruction or their genioplasty for the genioglossus advancement. If the tonsil grade is 3 or 4, is considered because the Mallampati is good, so we may consider tonsillectomy or pharyngoplasty. If the oral cavity is more crowded, so the Mallampati is 3 or 4, you can go see which occlusion they have. But no matter what occlusion they have, MMA or SMMRA is one of the good choice of these patients. However, go through this algorithm, you still can have incomplete remission or relapse of these patients. So if we have this kind of situation, we go back to the first line of BMI, go to see these patients' obesity or not, look at, go through these algorithm again, and if the patient really need another ailment, it will also be a choice. Thank you very much.
Several. So now we have several questions here. I think the first one goes to Dr. Xu. Do you use lingual braces for surgical patient? Can you use lingual braces in every case, excluding facial anomalies?
I'm too weak. I don't know how to do lingual braces. So I have no experience of lingual braces combined with orthodontic surgery at all. And in my thought, I think it will be very difficult because in the surgery, we need to do IMF. But if the braces in the lingual side, I don't know how to do that. Maybe we have to put some buttons or even some screws on the buccal side. So no, I don't have the experience of lingual braces.
Okay, so this, I think we move to second. Okay, so again, goes to Dr. Xu. How would you treat mild midline off and mild crossbite that occur as an early relapse after surgery? So this is for maybe class 3 with mild lateral-gnesism.
Okay, so I think the question can be divided into two parts. One is midline, and another one is the anterior crossbite. For the midline, I think every orthodontist can do the midline correction, and everyone has their own method. So just like the regular orthodontist, I think it will be common sense for the orthodontist. So I want to speak more about the crossbite, anterior crossbite. For the anterior crossbite, right after surgery, I have a protocol that is many orthodontists, when they see anterior crossbite, the first thing they will use is to use the elastics to try to pull the lower incisor back or try to pull the upper incisor forwards, and in that way to correct the anterior crossbite right after surgery. But I have different protocol. That is, the first time I saw the patient right after surgery, if I realized there is an anterior crossbite, then the first thing I will do is I will try to avoid any kind of any kind of elastics. Instead, I will put on the chin cap in case of skeletal class 3, because I don't want any dental effects to occur. Remember, when we are talking about surgery first, we talk about the RAP, the regional acceleratory phenomenon. So if you put on the elastics, it's very likely that you just pull the piece, but not the skeleton. But as I showed, there's one extreme, actually two extreme skeletal class 3 cases. The relapse will be the mandible moving forward after the surgery. So theoretically, I prefer to set back the mandible by extraoral force. So I use the chin cap to push the mandible in the backward and upward direction. And I will try, because the bone is not healed, around 3 or 4 weeks after the surgery. And so in that period of time, I will use the chin cap, try to correct the bone position. And also in that situation, I will try to evaluate if there's any occlusal interference. Sometimes the open bite comes from only one contact point around the teeth. So I can also not only use the chin cap, but also grind, to do some occlusal reduction to burr the piece a little bit, and some wedge effect. So I remove posterior like 1-2 millimeters. I can close the bite around 3 to 4 millimeters anterior open bite. Okay, so that's how I approach the case right after surgery if I see a anterior close bite, even the open bite.
So right now we already finished all the online questions. So then we proceed for the take a group photo together with all the online participants. And we have Professor Chen, Professor Lin, and Professor Liu here.
Testing. Okay. Hi, everyone. Please turn on your cameras right now, and then we'll proceed with our photo shoot. Okay, so we'll start taking the photos now. And since we have 6 pages of participants online, so everyone might have to wait for a little while. Okay, so we'll take our first photo. Please smile. 1, 2, 3, smile. 1, 2, 3, say cheese. And let's wave to the camera. Okay, and then let's proceed to the second page. Okay, please smile. 1, 2, 3, smile. 1, 2, 3, say cheese. And let's wave again. Okay, let's go to the third page. 1, 2, 3, smile. And 1, 2, 3, say cheese. And let's wave. Okay, for our fourth page, 1, 2, 3, smile. 1, 2, 3, say cheese. 1, 2, 3, wave to the camera again. We're almost done. Bear with us. Okay, our fifth page. 1, 2, 3, smile. 1, 2, 3, say cheese. And 1, 2, 3, let's wave. And for our last page, 1, 2, 3, smile. 1, 2, 3, say finally. And 1, 2, 3, let's wave. Okay, thank you everyone. And before everyone logs out, Professor Yuri Chen will be giving us a conclusion.
Oh, thank you very much that everyone stay up to now. And thank all the staff, speakers, and as well all the staff that work for us. And thank you to come to Chang'an Forum 2021. And we are looking forward to your next time, 2022. Thank you again. See you. Bye-bye.
Record